Welcome to the Functional Relations Podcast, where we set aside time to have engaging conversation. I had to swallow halfway through.
Yeah, man. Just take a deep breath before, so you're gonna.
Okay. Welcome to the Functional Relations Podcast, where we set aside time to have engaging conversations on relevant topics related to behavior analysis. I'm Zachary Bird.
And I'm Caleb Davis. How's it going, Zach?
Hey, Caleb. It's going pretty well. Thank you for asking.
How are things going? I feel like I haven't talked to you recently.
I know. Things are going pretty well. Our consultation company is growing. We're going to try to see if we can hire some behavior analysts to be behavior consultants.
Oh, that's exciting. That's kind of like a big step in your development, I guess, of your company, right? Like you're starting to expand.
Yeah, it seems like a big moment. Hopefully we get some good applicants.
Oh, yeah. Well, you hear that, everybody? I guess if you really wanted to work with Zach, you could move to Virginia.
Yes.
Or maybe you already live in Virginia and you just want to
Yeah, that's right. We live in the beautiful Blue Ridge Mountains. If you like hiking, you like the outdoors stuff, this is a great idea, Caleb. I'm going to leave my work email address right in the show notes. And if you're interested or you know anyone who might be interested in being a behavioral consultant for principled behavior consultants, send me an email. Zach, Z-A-C-H, at principledbehavior.com.
Well, there you go.
Well, that was a great advertisement. But I'm sure that people love to hear advertisements at the beginning of their show.
What a great way to start.
Yes. What have you been up to, Caleb?
Not too much. Me and my fiance went away for a week.
Fiance?
Yeah.
Congratulations.
Yeah, thanks. That's a more recent development. But yeah, it's really exciting.
Very good.
Anyways, we went away for a week, and my dog Toby.
Yeah, Toby.
We couldn't bring him with us, so I had to put him. We boarded him in a pet hotel place. It was like when he came back, it was weird. He wouldn't eat his food, and anybody who knows Toby knows that that's really weird. Like he usually crushes the food immediately. So I actually had to do a little analysis to determine what was going on.
Ooh, fancy.
So when
you're really putting that PhD coursework to work.
Oh yeah. So I sent him to the pet hotel with an unopened little package of the dog food that he typically eats.
Okay.
Right.
Yeah.
And so they said when he was there, he was eating fine, which
okay.
Business as usual for him. When he came back, I had another bin of food that I've had for a while.
Like an old bin?
Like an old bin of food or whatever. When I get it, I dump it in there and I just leave it in there, and that's what I feed him out of.
Yeah.
So that's what I was giving him when he came back, and he wasn't eating that. So I was like, I don't know if it's because he's maybe really stressed out that he just came back from the pet hotel and he's really worn out.
Misses his new friends.
Yeah, maybe, because he made these... He actually did. They said he made friends with a golden doodle. So yeah, I didn't know if he was just upset he missed his friends and he's just worn out. But anyways, for 2 days, when I would feed him, he was kind of picking at it, but didn't seem too enthused. So I was like, oh, well, I want to rule out to make sure it's not something wrong with the dog food. Right. So I basically just did a quick alternating treatment design where I gave him food from the bag that I'd sent with him that I knew he had been eating.
Yes, right.
And I alternated that with the food that he was not eating from the bin that I've had. And it was actually it was very clean analysis. He ate the food that I sent with him, and he didn't eat the food that I had in the bin for a while. So I chucked that bin of food, got him new food, and you'll be happy to know that Toby is now eating.
Oh, he's fine.
As normal.
Great.
So, but anyways, yeah, that's the excitement of my life.
That's a real feel-good story, Caleb.
Yeah, don't worry. Toby's fine.
Good.
But
well, we have our feeding troubles at home too. Our dog, Shama, she eats fine, but we do have a 2-year-old human in the house. So they're kind of known for picky eating.
Oh, yeah. Those are probably some more complicated feeding issues than my simple dilemma.
Yeah. Well, so it is interesting with Cooper. We always have vegetables and fruits that even if he's like not eating them, he still has them on his plate, and he kind of has to eat a little bit if he wants some.
Does he like vegetables and fruit or not really?
He does. But it's like we've exposed him to it for his whole life. Like we've kind of known a little bit about feeding sorts of treatments. And so we've never stopped providing him with fruits and vegetables on his plate, even if he doesn't really eat them. And so he really has learned to like carrots. He loves carrots.
Oh, interesting.
He will often dip them in ranch, but he is picky on occasion. And so we always kind of have this sort of, it's kind of silly, but so kind of what we do is we model the behavior we want to see. So we grab a carrot and we might dip it in some ranch, and we say, oh, watch this. And we bite it. And then we kind of do a little dance. We put our fingers in the air and we go, oh yeah, oh yeah, oh yeah, oh yeah. And
the
then
carrot dance.
Yep. And then and then he has to do it, and then we get to cheer for him. And this silly behavior, something about this silliness, he just loves it, and he'll eat carrot after carrot after carrot. It's really remarkable.
That's funny.
It's really interesting. So, he does pretty well, but I think it really has to do with kind of exposure. We've kind of modeled it, and we try to provide some kind of silly praise and dancing after he does it. So I think that helps. I think that goes a long way. But
yeah, I mean, I'm sure, obviously you and your wife, Angie, are both behavior analysts. So that I'm sure certainly has benefited you in kind of addressing any like pickiness around food. And it sounds like you've kind of come up with some creative ways to, make sure Coop's getting his veggies.
Absolutely.
In your work, like not with your own children, but like with clients and stuff like that, have you done a lot around feeding? I feel like that's kind of common. I think it's common in a lot of ABA programs to like, there's like a little, like maybe a program or two around like increasing like variety of foods or like different stuff like that. But have you done much work around that?
I wouldn't say I've done a lot of work, but I have done some. Let's see, I've done some exposure programs, and I've done, some sort of pre-Machian programs. I'm not really an expert in it, but I know some basics. How about you?
I think I'm similar boat. Like I've certainly designed programs not to address like severe feeding issues, but like sort of basic like increasing variety and stuff like that. I've certainly read a lot about it in the sense that like there just seems like there's a lot of different treatments out there, like the high P sequence, and like you eat some highly preferred foods and it's followed by maybe a vegetable or something you're not like. So I just feel like I've like been exposed to a lot of that stuff, but certainly like I think like an area that behavior analysts often encounter, right?
Oh,
but
yeah. I think there's been some great work in it. I think that, in the literature, there's just a lot of it. So that's a pretty interesting topic.
Yeah. Like I'd be interested in talking to somebody who is like an expert in feeding. Cause again, like I think it sounds like our exposure to it is sort of like in, common,
kind of basic.
Basic, like let's try to increase, variety or things like that, or decrease like the pickiness of somebody's eating. But like, I would really be interested to talk to somebody who, treating feeding issues is their thing. They know a lot about it. To kind of just hear from an expert, like what's the deal? Like what should behavior analysts like be thinking about when they're assessing and treating and doing all that stuff? So I don't know. I think it'd be cool to have somebody on here that could, talk to us about that.
I think that's a great idea. We could find someone who has a lot of experience, a lot of expertise, and see what they can tell us about it.
Dr. Bill Ahearn, thanks for joining us and welcome to the Functional Relations Podcast.
Nice to talk to you both.
Dr. Bill Ahearn is the Director of Research for the New England Center for Children and the Chair of the Board of Allied Mental Health in Massachusetts.
So today on the episode, we're discussing feeding problems. And something I'm wondering is, I know some individuals are often considered picky eaters. How do we make the distinction between a picky eater and someone who has a feeding problem that actually requires treatment? So would you mind defining what a feeding problem is?
Sure, it's a really good question, Caleb. So when we talk about picky eating, selective eaters are really more the rule than the exception. It's estimated that somewhere around 2/3 of the population of typically developing people have some pickiness or selectivity to their eating. However, selective eating and food refusal really are very different kinds of problems. A child that refuses to eat obviously gets themselves into trouble very quickly, whereas someone who's just a picky eater, if they consume enough calories to gain weight and grow, to some extent that has to be taken into consideration. It may be the case that they eat just macaroni and cheese or just chicken nuggets. In the grand scheme of things, if they're getting enough calories to gain weight and grow, you have the luxury of a more thoughtful, thought out, and patient approach to dealing with the feeding issue. So if you really want a definition, I think I like to sort of view feeding as being two kinds of things. You either have a severe feeding problem like food refusal or food selectivity to the point of not gaining weight and growing, or it's causing other health problems. And you have feeding issues that are not severe. Now, those that aren't severe, someone who has picky eating, but let's say they are generally eating the same sort of thing every day for breakfast, same thing every day for lunch, the same thing every day for dinner. It's kind of like all of us in quarantine right now.
Yes.
It's also if there's a variety to each of the meals, like eating cereal and maybe yogurt for breakfast, and let's say peanut butter and jelly sandwich for lunch, and then some dinner that is regularly consisting of whatever it may be, chicken nuggets, mac and cheese, whatever. There is some variety there, and whether that is the child's most pressing problem or concern is really something that needs to be taken into consideration before you decide that this is something we're going to attempt to treat. Does that make some sense?
Yeah, I think that's super helpful, Bill. I know in my experience, it's not uncommon for individuals diagnosed with autism specifically to kind of be selective eaters. How does the prevalence stack up between individuals diagnosed with autism and their typically developing peers?
Sure. The data on this is not, ironclad in any sense. But when I first came to the New England Center, I actually had an opportunity to survey the feeding habits of kids with autism. It was a question that I had as a clinician. I'd been working at the Seashore House with primarily individuals with very severe feeding problems, mostly chronic food refusal. And a number of the individuals that sort of came up the pipeline into the inpatient unit with somewhat more mild presentations oftentimes were kids that had an autism diagnosis. So I became interested in studying more about autism and feeding. So in the published literature up until that point in time, there certainly were lots of anecdotes about feeding difficulties in individuals with autism. The survey that I did at the New England Center involved, or I should say, consisted of presenting meals across a number of days to children with autism, sampling from the New England Center's cafeteria. So there was a variety of food being presented. We had a fruit, vegetable, a starch, and a protein that we were presenting at each one of the meals. And what we found in our study is that we had evidence of selectivity with about 50% of the kids that we were working with. Now, the backstory to that is if a parent that we had sent a request to consent two said, "Oh yeah, my son or daughter has a real significant feeding issue," we actually didn't include them in the study. We worked with them the outside of that, but we were just trying to survey the feeding habits of kids that weren't being listed as someone who had feeding as a concern. So that sort of gives me a baseline. I would expect that somewhere around 50% or more of individuals with autism have some issue related to feeding. So what do you mean issues related to feeding? Many of those, like I just mentioned, that are typically developing are picky eaters. That's something that seems to be even more prominent in individuals with autism. And some surveys of feeding habits that have been done by using questionnaires with their caregivers. Some of that work's been done by Keith Williams and Kim Schreck, I believe, from the Hershey Medical Center. Suggests that we're talking about probably at least 50% of individuals with autism with some sort of feeding issue.
Yeah, that's really interesting. I like that way to analyze it. That's pretty cool. So just to make sure I understood, you have picky eaters, which is just like a high percentage of the population in general, and then you have people who are not eating enough to really stay alive, and then those situations you really need to definitely intervene with some feeding treatments. Now, when you have someone who is kind of a picky eater, do you think that these are things that most behavior analysts can manage on their own? And then at what point would you say you should really go out and get some expertise on a more severe feeding problem?
Right, two really good questions. So if I don't answer them both fully, make sure you go back to them. Let's start with picky eating. If a child is a selective eater, and the concerns that you have about that case don't involve self-injurious behavior or other severe problem behavior as being a real focus, then picky eating is definitely something that can be addressed by standard behavior analytic procedures. Now, there are a whole boatload of caveats to that, though. Number one, I generally only would want to work on an individual's selective eating if their parents were concerned about it and invested in doing something about it, because
good point. Yeah,
it really takes the focus of the child's entire community to get to an endpoint where we have everyone sort of going in the same direction. Oftentimes, what I do at the beginning of sort of deciding whether or not we're going to recommend intervention for a feeding case is I have a diet record that I collect for the child for about a 2-week period of time when there are no unusual activities. So I wouldn't do this at Thanksgiving or Christmas or when the family's on summer vacation. But I try to get a good picture of what is being presented to the child, number one, and number two, what they're consuming based upon what's being presented to them. So during this assessment process, it usually becomes pretty clear that the child's diet consists of a certain, number of foods, and I look at those in terms of food categories. The way that I sort of chunk out the feeding world is there are fruits, vegetables, starches, and proteins. If somebody is a selective eater, they're most likely to be selective for starches and proteins, and oftentimes starchy proteins. It's kind of why I talk about chicken.
Yeah.
Personally, I hate chicken nuggets. I'm not of breading or deep frying, but it certainly is the case that if starches and proteins are the primary constituent of an individual's diet, they're probably going to be getting enough calories as long as there are no other issues. So a goal oftentimes then comes up as to, well, what are we going to target first? And we can get into treatment and strategies a little bit later.
Yeah.
But in terms of identifying where you want to go, taking the family's diet into consideration is very important. You want to be well aware of what the family eats. So mom and dad have their eating habits as well, and interfacing with the family about what their diet is like is oftentimes very helpful in identifying what we would like to target the child to eat, so that we can work on those things that are going to be naturally incorporated into the day-to-day eating habits. So let me just say one more thing about the assessment process. Very frequently, especially when I'm working with young children, like 6 or younger, and a family is concerned about the child's eating, and we go in and we do that assessment across a 2-week period of time, what they are eating. Sometimes, and I'd say a very good percentage of the time, we find that the kid's actually doing okay. And having that as a baseline check-in, and then to sort of reflect back to the parents, here's what they're eating, here's what you're reporting they're eating, and this is where that would place your child in terms of degree of selectivity. So
yeah, right.
Someone that's severely selective, generally we would say, is eating from just one food category or maybe 2 food categories with no more than, say, 3 to 6 items, in their in the variety that they accept. A more moderate, least selective eater obviously would have a little bit more variety, and a mildly selective eater might be somebody that samples from at least 3 of the food groups. I see a lot of kids that will either accept fruit or they drink juice, but it's very limited in terms of the variety, or they'll eat like one vegetable. And in the grand scheme of things, that's not really too bad. That's mild. And it's at that point in time that we then have a team conversation, the families and the other folks that are working with the child in addition to the behavior analyst, as to what's the priority for this particular case. Is it feeding, or should we, work on our other priorities and just monitor what's going on here and maybe do another food log in about 6 months? And as long as the diet isn't becoming more narrowed, we can just sort of let it go. And there are things that we can usually offer to the parents as generic suggestions, like make sure that because he eats apples or applesauce, that you're presenting apples or applesauce frequently.
Hey, sorry to interrupt, but if you're a BCBA or BCABA and you're interested in getting a CE for listening to this episode, you can purchase it at functionalrelationspodcast.com. This episode is worth 1 learning CE, and you'll need to provide 2 code words when you go to check out. The first code word for this episode is pizza. 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 I like cheese, sauce, and pepperoni on my pizza.
And in those cases where we make the decision that the diet is overly narrow, sometimes there are also other health concerns that go along with that. If they're eating primarily starches and proteins, we may find that the child is chronically constipated, and dietary fiber might be something that would help that situation out. Then we want to take all of the sort of factors into consideration before we then decide, okay, now we're going to go ahead and do something. So let me pause and let you ask any follow-ups that you would like.
Yeah, that was great. Yeah, these are really interesting. Man, this topic, it's so interesting. So I think one of the things that is kind of on my mind is, okay, we have a picky eater, and I think that people use, pre-Mac principle, grandma's law, as they say, and there are some kind of basic behavior analytic strategies we can use for picky eaters. But I'm wondering, at what point do we reach out to someone like you or a feeding expert, because we're a little bit outside of our scope of practice for what we've been trained for? Where do you draw that line?
Sure. Well, I know that you two, like very many practitioners in our field, when you encounter a problem that you haven't had a ton of experience on, you're probably going to start to do some reading. You're going to comb into the literature and see, well, what are the effective intervention strategies that are out there? For feeding, I think it's really important for us to look beyond the published research literature. There are a number of books that have been written and book chapters. I've, in fact, written a book chapter, although I'm not here to promote that. I'll promote somebody else's work. I mentioned Keith Williams earlier, and Keith and Richard Fox have written a book on pediatric feeding problems that is an incredibly practical resource to learn more about feeding and what sorts of strategies are available for addressing them. But when we come to what are the tools that we use, my suggestion in those cases in which we have selectivity is to actually not jump into reinforcing eating right away. There are a couple of reasons for that. One is when we see picky eating, sometimes that picky eating is the product of sort of a dance between the parents and the child, whereby the parents are presenting certain foods, the child refuses to eat some of them, and so naturally the parent, through absolutely no fault of their own, because this is a very natural contingency, stop offering the foods the child's not accepting. The variety of food being presented to the child oftentimes becomes more narrowed because of that dance, right? So one of the first things that I like to try is exposing children to new foods. And by new foods, I mean foods that they're not regularly consuming, those that maybe they've consumed in the past, but now they don't, with no contingencies in place, but consistently presenting these foods to them to offer an opportunity for them to approach. Sort of use that as a baseline strategy before incorporating any other behavioral interventions onto it. One thing that I found, and this really started with that survey, Feeding Habits, that I was talking about earlier, which is published in Journal of Autism Developmental Disorders in 2001. One of the things that I witnessed with some of those participants is that initially they really weren't sampling a variety of foods. They were mainly just consuming what they presumably preferred. But as we continued to present foods to them without sort of taking away those that they were refusing, I found that there were a couple of kids that were starting to just pick up new foods that they hadn't consumed before. So
interesting.
I like to use that strategy of exposing the child to new foods before I decide whether or not they'll consume them. So that's sort of a step one. In terms of what other things might you incorporate, well, reinforcement is obviously one of those things. Do you withhold a preferred food contingent upon trying, something that's novel? That seems like a pretty typical naturalistic strategy that you might use with your own kid, assuming that you had kids. Mine are grown.
You don't do it anymore then?
Well, I don't do it any less either. But in some sense, that kind of a naturalistic strategy, it can work, and there's evidence in the published literature that might work. So you can have successive presentation. So eat this, and you can have access to that. However, I've also worked with a lot of kids for whom, as soon as you start that successive presentation strategy, they don't want the thing that's preferred anymore either.
Interesting.
So
you
just narrowed the diet down. So you got to be careful. I would tend to avoid going directly to that sort of contingent reinforcement if the kid was overly selective and their weight was a little bit dicey.
Okay, that makes sense. Yeah. That's good. So at what point do we say, okay, I'm going to reach out to Dr. Ahearn, or I'm going to reach out to someone else in the field who might be an expert, because I just don't feel comfortable working on this person because they're losing weight or something. I mean, what's the point that we should be reaching out to someone?
Well, definitely if you're working with an individual that's failing to thrive or has chronic or acute food refusal, chronic meaning they don't eat at all, or acute meaning that they might go through periods of not eating, but then eat subsequent to those periods, you're probably going to want somebody that has pediatric feeding expertise to be leading the intervention team. Now, that said, when I have a child who I suspect has a good reason to not want to eat, and that's sort of how I, as a feeding clinician, view feeding problems, there are oftentimes good reasons to not eat for those kids that have food refusal, be it acute or chronic. And in those cases, I, as someone who has behavioral feeding expertise, would like to have collaborators from other disciplines. Very interested in the pediatrician. And if there's some reason to suspect that there's some GI involvement, a pediatric gastroenterologist to see the case and make sure that they feel there are no medical reasons that are contributing to the feeding problems. Now, I don't mean this to be disparaging to other disciplines, because I certainly don't mean that, but gastrointestinal difficulties in children, particularly those that are either chronically or acutely refusing food, are sometimes very difficult to identify any of those contributing problems. If you're not eating, right, there's no food going into there, so there's really a much lower probability of there being reflux or other evidence of a good reason to not want to eat coming through. But sometimes those pieces of the puzzle exist in the child's feeding history, which is why it's very important to take a look at the child's medical record relative to their eating status. When I have that kind of a feeding case with the expertise and those that I've collaborated with from other disciplines, I've learned the importance of taking a look at the child's birth weight and then the history of their weight and growth from that point in time until when I'm encountering them. I also like to take into consideration where that child should be. So if they're, both of the parents are 6 feet tall, but this child's very small, genetically we would expect them to be there. So you're really concerned. But if the kid's, say, on the 20th percentile and both of their parents aren't very tall, well, then maybe they are where they need to be. And that's where it's good to collaborate with a pediatrician and a pediatric gastroenterologist on those issues. There are other disciplines that can be critically important to the success of a feeding case. I've worked with lots of kids with oral motor issues, as I'm sure both of you have. And oftentimes children with oral motor difficulties end up with feeding problems that are at least partly contributed to by their oral motor deficits. So I oftentimes work with individuals with dysphagia expertise that are speech and language pathologists on cases like that. And occupational therapists, some of them have dysphagia expertise, and particularly those with a lot of full body tone involvement, like those with cerebral palsy, oftentimes need special accommodations for positioning while feeding. So those disciplines can be very critically important to success of a case.
Yeah, that's super helpful, Bill. And sounds very complex too. You have a lot of different people you might need to reach out to depending on what you suspect might be going on. You mentioned a little bit about treatment as far as like exposing kids to maybe types of foods that they typically refuse, and that in itself might result in some increase in consumption of food. what are some other common treatments behavior analysts might want to become familiar with that they could use to treat sort of like these more common feeding problems?
Sure. Well, I mentioned that you might not want to use access to a highly preferred food contingent upon eating a novel or non-preferred food. But reinforcement can be very effective as a means of addressing feeding problems. I just tend to shy away from using food as the reinforcer. If I have very effective reinforcers, I attempt to do my best to isolate them and provide contingent access to them for targeting. But that's only one of many potential strategies. So I mentioned successive presentations of food. So you have a novel or a non-preferred food, and for consuming this, you get to have then something that is highly preferred. Well, that successive presentation strategy will sometimes work, but there's another possibility, and that's simultaneously presenting a preferred and non-preferred or preferred and a novel food. And there are a number of ways that can be done. That simultaneous presentation has some evidence in the literature as being effective. One example. So I was working with a young man who wouldn't eat vegetables, and this was a student at the New England Center, and his teacher was very invested in having him eat vegetables, partly because he would eat his vegetables if he was given a choice of condiment to put on it. So if he had access to some salad dressing or some mustard or barbecue sauce, by the way, those were the the highest preferred, I should say, condiments, because in fact, do a condiment preference assessment.
Very good.
Nice.
Like a true professional.
That's right. This is a published study too in Java. And we provided him that simultaneous presentation across a variety of vegetables, and he was consistently consuming them when he was given access to a condiment to have on the vegetable. In fact, ultimately, what we did to control teacher behavior is we taught him to use PEX icons to request the condiment that he wanted for that particular meal, so that he was initiating the demand for the condiment that he wanted with those vegetables.
Yeah, that's a great example of, I guess, individualizing treatment for sure. With behavior analysts who are maybe interested in treating some of these issues, do you have any resources that you would recommend people look at other than the numerous articles you've already sort of cited as you've been discussing these examples?
Well, when we take a look at an individual, that individual is going to present in a variety of ways. However, if we look at an individual type of problem behavior, like pediatric feeding problems, there are really a wealth of resources out there in the form of books and book chapters. I mentioned the book by Keith Williams and Richard Fox. There was also one that was written by, I'm pretty sure it was Jorgen Kedesti, who previously worked at UMass, the UMass Medical School. That's also a very effective resource. It's called Childhood Feeding Disorders. And I'd be happy to send along some general references for you guys, but I've also done a number of workshops that sort of give a broader overview. And I'm not saying that you have to find my workshop. There are a number of folks with wide expertise in pediatric feeding problems. The most notable being Kathleen Piazza, has done fabulous work on pediatric feeding disorders. There's the group at the University of Iowa, Linda Cooper, has done some fabulous work on feeding. And I really think that if you go out there and search for those folks that are publishing now, you're going to find that the sources that they're citing about pediatric feeding disorders generally are going to be pretty useful. But I also offer up to any behavior analyst who's interested in learning more about pediatric feeding disorders, having them email me, because I'd like to share the information that I have and help steer folks in the direction of the resources that are going to be most useful to them in the case or cases that they're encountering. So my email address is something you can also post and not feel guilty about posting it.
Yeah, that's very generous of you. We'll make sure to post any of the references to the book chapters or the articles that you send to us. We'll make sure to put it in the show notes. And then we'll also put your email address in the show notes so that people can contact you if they're trying to find a particular direction. Where are they going to go? What direction are they going to take for a particular case, and where they can find out more information about the types of treatments. Is there anything else that you'd like to say today that we haven't hit on yet as it relates to assessment or treatment?
Let me just sort of get one thing out there.
Sure.
As behavior analysts that treat problem behavior frequently, the gold standard is that we conduct a functional analysis in some way, shape, or form before we go into developing an intervention. There are some functional analytic strategies that have been used with pediatric feeding disorders. And I'm going to just pause a little bit for effect here, because this might seem heretical. Functional analysis is not necessary for developing your intervention strategy for a pediatric feeding problem. A careful assessment of the individual's eating and collecting a number of associated pieces of information are really what you need to do. Because feeding, when it is a problem, be it selectivity or be it refusal, always involves escape. Escape from the non-preferred food. And what is non-preferred versus novel is irrelevant. If they're not accepting foods, you can treat that as an aversive stimulus, right? So there, in some ways, there are sometimes categories of problem behavior where and not many, where the function is consistent. When we work with individuals with stereotypic behavior, it is automatically reinforced behavior the vast majority of the time. There's very little evidence to suggest that there's social mediation for stereotypic behavior. There are certainly idiosyncratic cases that I've encountered over time where that's the case, but the vast majority of individuals with stereotypy, the stereotypy is maintained by the sensory consequences engaging in the behaviors producing. Similarly, with pediatric feeding disorders, particularly food refusal, it involves escape from an aversive event. So conducting a functional analysis is something that really could gum up the works and take much longer or add a lot of time onto your assessment when you could be doing other things that are going to be more productive for putting together an effective strategy that's going to lead you to a better behavioral program. So that's an assessment.
Oh, that's awesome.
When it comes to treatment, if I was going to say a couple of things about treatment, is don't think that one treatment is the best approach for everything. Exposure might be a good starting place for all kids that are selective, but many children that are selective eaters are not going to be particularly responsive to exposure. So what's the next step? Do you go right to attempting to positively reinforce eating? Well, that depends. If I have a child that has very potent reinforcers and works hard for them in other situations, reinforcement, you might effectively develop a strategy that would work for the feeding problem too. But for those kids that don't have a lot of potent reinforcers, you may not want to jump to reinforcement right away. There are some folks that suggest doing something along the lines of fading in acceptance of the food. So first you have the student pick up the food, right? Then you have them bring it to and touch their lips. And then ultimately you have them put it in their mouth and then chew and swallow. Those sorts of strategies are potentially effective. I'm not going to endorse them because I found that they are oftentimes interventions that have been tried before people come to somebody like me to help them out with a very difficult to treat feeding problem. However, I know others have had success with those types of approaches. The simultaneous presentation of foods is something that if you have a child that likes condiments, for instance, that's probably a place that I would go before using reinforcement if that was available to me. If I have a child that is eating primarily mushy or mostly pureed foods, well, I might actually work on the variety of their food acceptance by blending foods together and then gradually fading out the preferred food to see if we can maintain acceptance at the puree before I then attempt to advance texture from the pureed foods to regularly textured foods. And finally, the strategy that we would like to avoid with feeding problems, but is oftentimes unavoidable for very severe feeding problems, is preventing escape. In any situation in which that's being considered, I would strongly recommend that you seek out expertise in behavioral interventions for feeding problems before you go down that road.
Oh, that's very good advice. Yes. Oh man, this is great. This was such a informative and interesting topic. I think when I first started thinking about feeding disorders, we were thinking this could be a really interesting topic, but then it's turned out to be way more interesting than I thought originally. So I really appreciate the time that you took with us today, Dr. Ahearn. And we wanted to know if you had anything else you wanted to say before we end today.
So you guys are being like Jesus and Meryl. I get to have my neon sign above me at the end here. And by the way, if you've never watched the show, I highly recommend you look at it because it is hilarious, allegedly. If you're going to ask for sort of something to end on in this particular topic, my message to folks would be go out there and consume information and talk to other people that are dealing with feeding problems and benefit from the experience of those that have been doing this, because there are many effective approaches, and we have, as a field, behavior analysts have had a great deal of success with pediatric feeding disorders for a very long period of time. The literature that I first encountered when I started working with pediatric feeding disorders was work that was done by Mary Reardon with Brian Awada in the 1980s. That literature is a very mature literature, and it is one that has provided us with pretty much all of the essential tools we need to be effective in those environments. The one thing that is missing, if you haven't done it, is experience. And there's no reason why you can't get to that point yourself.
And we're back. That was an excellent interview. But before we get into it and discuss it, we want to just take a little bit of time to show our appreciation for all the people who support us.
Yes, absolutely. Thank you to everyone who supports us in a variety of ways. You know, we appreciate any reviews you leave on Apple Podcasts or iTunes, any comments on our Facebook or Instagram posts. And, if you ever need anything, you can send us emails at functionalrelationspodcast@gmail.com.
Yeah, and don't forget about Patreon. So if you are interested in supporting us in more tangible ways, feel free to check out our Patreon page.
Yeah, Patreon is a website that allows our listeners to access behind-the-scenes posts. We have a blooper reel. We put some updates up there about our future shows and our future seasons. And we also send out some small gifts to our members to show our appreciation. If you're interested, you can learn more about becoming a Patreon member at www.patreon.com/functionalrelationspodcast. We'll leave a link in the show notes if you're interested.
Yeah, so thanks again to everyone who supports us. We certainly couldn't do all this without you.
That's right. Yeah, Caleb, this was great. Should we discuss our interview now?
Yeah, let's hop right into it. So I thought it was a great interview.
Me too.
Dr. Ahearn knows so much about this topic, and we were lucky enough to have him as both a professor in grad school and then also consultant on some of the cases that we worked with when we were at NEC. So we kind of got to see firsthand some of his work with consulting on feeding issues. So it was really cool to be able to have the opportunity to talk about that with him, for sure.
Yeah, I thought that he had a lot of great tips and suggestions for us. The one that kind of struck me was about this exposure treatment option.
Yeah.
And we had done a little bit with this based on his consultation at the New England Center. Do you remember that?
Yeah. I certainly can remember at least one case where that method was used. And actually, I was surprised because initially that procedure to me is a surprising, because you're just exposing somebody to foods, right?
You're basically just being like, here's a tomato. Wait 10 seconds. Okay, you didn't eat it. I'll take it away. Okay, here's an Oreo, which they obviously like. They eat it. Okay. And then you're like, here's a cucumber. And then they don't eat it. And then you just take it away after 10 seconds. And then after a number of trials, they just pick up the cucumber, kind of look at it, and I might put it to your mouth. And if you're just watching this, it's really kind of remarkable how over time it just seems to work.
Yeah, it sounds like, maybe it doesn't work for everybody, but I mean, the way you're talking about it sounds like you've had some success with it. I know I've seen it be successful the time it was used that I was around, but have you continued to use that since then?
Yeah, I basically sent an email to Dr. Ahearn to get the protocol for exposure, and I've been using it. I've used it probably 4 times so far in the last probably 5 years or so, and it's worked. I think it's worked every time. The interesting thing is that I've even noticed that it's a certain kind of range of trials that it takes and it starts working.
Oh, really?
Yeah. So it's it seems to be somewhere between 150 to 250 trials or presentations, and then it starts to work. But think of how patient you have to be, right? People want their treatments to have an immediate effect, but this is a treatment where someone's not, their health isn't in danger because their lack of nutrition or lack of calories. So we have time to wait. And if it works, we can add some foods to the repertoire. That's the way I think of it.
Yeah, I just find it such an interesting approach, right? Because it sounds like this is sort of
for sure.
Maybe an initial approach, maybe a baseline, but maybe it also has some nice treatment effects. But just this idea of no contingencies, I think that's probably a strange thing for many behavior analysts to think about. At least for me, I remember when I first heard the procedure, I was so it's there's no contingencies. It's there's no escape contingencies. There's no contingency for eating. It's just here's the thing. If you don't eat it, that's fine. If you do eat it, that's also fine. And I'm just going to keep doing that for hundreds of trials, like you said.
Right.
And I just think it's such an interesting procedure and very simple, I guess you could say, right? Because you're not in a struggle with the client or anything, right? You're just kind of like you said, eat it if you want. If you don't, that's cool.
Yeah. And it does have this kind of neat side effect, I think, which is that the behavior problems start to kind of fade away.
So specify what behavior problems.
So escape behavior. So you might see if someone's trying to say, okay, first eat the carrot, then you can have your brownie or whatever, and then, you might see the throwing of food sometimes or just the running away from the table or,
Oh, that makes sense. Yeah. So maybe
hitting or I don't know. There's a lot of different behaviors that might emerge.
I mean, I guess that makes sense that over time you might see less problem behavior, specifically escape behavior, right? Because if you're not quote unquote forcing somebody to eat the food and they don't have to eat it, then over time, after being exposed to that lack of contingency, then it makes sense that maybe there would just be no motivation or reason to engage in problem behavior, right?
Exactly. Yeah.
So I feel like that makes sense conceptually. Like over time, you would just see less problem behavior.
Yeah, it's a nice thing because it makes the treatment simple. So you're not doing anything that's going to cause more problems than you already are having. And you might get a few extra foods in the diet. So that's that's just a nice, simple treatment. But he did seem to say that we shouldn't be over-reliant on a single treatment, right?
I mean, it sounds like you've had great success with that exposure procedure, but I mean, by the sounds of it, that's not always effective, right? So it's like,
sure,
if that's not effective, you may need to look at other procedures. And he described a number of those. There might be like some kind of like some pairing procedure where you like the condiment example. You remember when we talked about
adding
that?
Condiments.
Yeah, like it's not like a reinforcement contingency or anything. It's just you're adding something to maybe a non-preferred food that makes it better, right? So like Cooper, you originally in the intro talked about like dipping the carrots in ranch, like
right.
It's very simple. Intuitively, it makes sense that's something you might try. That I found really interesting was that he cautioned against using like a highly preferred food to reinforce consumption of like a non-preferred food. Right?
Yeah, sorry, Grandma.
Right, which I just find that really interesting, and the idea that possibly somebody might stop eating the highly preferred food because for some reason like that contingency or this I'm not sure exactly why.
I've actually seen that happen.
Oh, you have? Okay.
Yeah. So because if the highly preferred food isn't enough to reinforce the low preferred, then you get escape from the entire situation.
Yeah.
So it
really backfires, right? Because then they're eating less than they were before. So
right, exactly.
So I thought that was like a really cool and useful recommendation. Like if you are gonna have like a contingency like that, maybe looking at highly preferred non-edible items.
Yeah.
But even that, I mean, it sounded like one of the take homes from that conversation was no single treatment's gonna necessarily be effective for everybody. And so you might have to look at different options, right? I know, I actually have an example of this where I had a client one time where we're trying to increase food consumption. Okay. And so I had a reinforcement contingency, or my hope was that it would function as a reinforcement contingency, that upon eating like this healthy food, the client would get access to like one of their favorite things, which in this case was like an iPad or something.
Okay. So not a food item, but not a food item, very highly preferred.
And it didn't work. Like it didn't increase food consumption. So I got like digging around in the literature, and there's actually this study.
Good for you, Caleb.
I know.
Good for you.
And there's a study, I think it's Wilder et al., 2005, where they used non-contingent access to like a video or something during mealtime to increase food consumption. So it's like non-contingent access to like a video while you're eating, and like that was
it's just like me at the movies.
Yeah, right. You're just
I eat lots and I don't even realize I'm eating it, and I just ate a giant thing of popcorn and some candy.
Yeah, so there's like examples, or at least this example of where like if you provide just like something non-contingently during a meal, it might increase food consumption. So I actually tried that, and it actually was effective.
Boom.
So the contingent iPad was ineffective. Non-contingent during the meal was effective at increasing. So I was like, okay, interesting. But
very interesting.
I think that is just an example of you kind of probably on a case-by-case basis need to like look at what are the options for treatment. There might be other kids that maybe that would be effective for, but in this case it wasn't. So I think like being aware of things to try until you find the magic formula.
Hey everyone, if you've been listening to this whole episode and you're interested in getting a learning CE, the second and final code word is TWIST. TWIST. If you like chocolate ice cream and you like vanilla ice cream, you might like to try a twist. When you finish the episode, head over to functionalrelationspodcast.com to purchase your learning CE. Oh, and also, if you're in need of ethics CEs, you can get 2 ethics CEs for any of our episodes from season 1. Yeah, it sounds like there are a lot of good options for treatments, so I think we should make sure that everybody knows what to do if they want to kind of learn more about this.
Yeah, I think Dr. Ahearn provided us with some, and our listeners with some good resources, right? Like, so he mentioned several books that are, about treating.
Yeah,
feeding.
I ordered one of them already.
Oh, you did? Which one?
Yeah. Yeah, it was the Keith Williams, Richard Fox book. It's called Treating Eating Problems with Children with Autism, Spectrum Disorders, and Developmental Disabilities. Interventions for Professionals and Parents. I can't wait for it to come in the mail because it looked like a great resource. So I'll let you know how it goes.
Yeah, I mean, just by the title, it sounds good. And obviously, Dr. Ahearn recommended it, so presumably it's a good thing to have on your shelf.
Absolutely.
Also, I think some studies that Dr. Ahearn has published himself that were mentioned, so we'll be sure to put those in the show notes.
Mm-hmm. And he also mentioned that there are some really good workshops. We know that Dr. Piazza and others have done some workshops, and maybe Dr. Ahearn as well. I don't know if he's still doing them, but you could probably catch one of those at a ABAI, or maybe they'll do some webinars. Just keep an eye out. Those might come up, and that would probably be really useful as well.
Yeah. So, yeah, I think overall, I really liked this episode. I thought that there was a lot of great information, and I certainly learned some things along the way. So hopefully everybody listening was able to take away some things that they can apply in practice and know where to go if you need to learn more about stuff.
Absolutely. Yeah. Oh, yeah. And Caleb, I'm still hiring for that behavior consultant position. So if anyone's interested, maybe they could check out our show notes and send me an email.
Yeah, that's right. Yeah, that could be a cool opportunity for somebody who is looking to be a BCBA in Virginia. Maybe they already live in Virginia. Yeah.
Yeah. You also might be a BCABA who is working on their coursework. That could be an opportunity too.
Oh, okay. So somebody who's like either a BCBA or BCABA.
Yep. And we probably want someone who's working on their coursework. So as always, you can get a CE for this episode. So if you're interested, jump on to functionalrelationspodcast.com to get a learning CE. And I guess we'll see you next month with a new episode.
All right. As always, Zach, it was a pleasure. I'll talk to you later.
Thank you, Caleb. Talk to you later. Bye-bye.